Hello, Professor Reinstein. Welcome to Dubai. First thing I would like to ask, is this your first time in Dubai?
This is my first time at EPOMEC,
Okay.
and I hope not the last.
Okay. Since it's your first time at EPOMEC, how did you find the organization? How did you find, it was your first session today.
Yeah.
What's your first impression?
Yeah, this is a really well-organized meeting. Certainly, as a speaker, I was treated beautifully, exceptionally. The meeting is really interesting. You've got several rooms, and I like the way that you have a large room that you can either give one big lecture in, or you can divide it into three different lectures at the same time. So it gives the whole feeling of a lot of people together, even if you're listening to different sections. I like that idea.
That's nice. Thank you. You're this year's recipient of the Ibn Nafis keynote lecture and award. I would like to just a quick preview. What are you going to talk about? Just, as a quick summary.
Well, Ibn al-Nafis, like many other Arabic medical scientists, developed Western medicine. What we call Western medicine comes from this region, Mesopotamia. This area was really the area where the early scientists were dissecting bodies and trying to learn physiology, and we're looking at a mechanistic approach. Right, while in Europe, the hoity-toity physicians to the royal families were smelling the poo, tasting the urine, bleeding people to death, putting leeches on them, and I think a lot of praying. I think there was a lot of clergy involved in medical care in Europe at that time. So it's very special for me, actually, to be invited and to be giving a talk with Ibn al-Hafiz as the name lecture, because I know that he wrote one of the first textbooks on ophthalmology. But of course, he was also really documented to be the first to have discovered the pulmonary circulation. And when I was at medical school at Cambridge, they didn't talk about him. They talked about the European, Harvey. So it's kind of interesting. Well, there was no WhatsApp. There was no Instagram at the time. So I guess it was difficult to transmit information. But it's a great honor to be at the seat of modern medicine here.
Thank you. Thank you so much. So for those who won't be able to attend but would like to know, what are the key messages and take-home messages of the talks you're going to discuss? Would you like to share some of the most important pearls?
Well, in the tradition of Ibn al-Nafis, I would like to speak about something that was described a long time ago, but was pretty much ignored for a couple of decades, in his case, many centuries, which is now resurfacing in a different format. And, money talks. So this subject is EDOF. And what I'm going to talk about, and I'm going to demonstrate, is that extended depth of field, without compromising contrast sensitivity, was discovered in the early 2000s. I noticed when I was treating my patients for night vision disturbances, after the spherical treatments that we were doing in the 1990s, that we could reduce the spherical aberration of an eye and improve night vision disturbances in contrast in these patients. What was disappointing for me at the time was that we were only reducing the spherical aberration by about 25%. And I thought that wavefront guided didn't work, because if you can only reduce it 25%, that's not exactly the same as flattening the wavefront, which is what we'd been promised, right? Well, the bizarre thing is that the patients were coming in with this disappointing 25% reduction in spherical aberration with perfect contrast, and explaining that their night vision was crisp and that they could see like they did before with glasses, before the surgery, without glasses. And that observation, that discrepancy, between what I was seeing on paper and what I was hearing from the patient is what led me to the, wait a minute. This is why a hyperopic patient who's plano after hyperopic LASIK can read. It's spherical aberration. Wait a minute, their contrast is normal despite there being high levels of spherical aberration because the brain must be filtering it. And so just on that, I started working with Tim Archer on modulating spherical aberration in the profiles. We had direct access to the wavefront file back in those days. It would never happen now, but you could just open the MDB file. It was a Microsoft MDB, it wasn't locked. We just write in the spherical aberration and put it on the eye. Now, we didn't do it like all at once. We went in very, very small increments, and we essentially had about 800 eyes that gave us a master three-dimensional nomogram of how sphere interacts with spherical aberration and what the dose response curve is of how much spherical aberration you put in and how much spherical aberration you reduce from the expected induction level, which gave us a way of modulating spherical aberration. And then realizing that we could get about 1.5 diopters of depth of field with the maximum spherical aberration before losing contrast, we then said, okay, we'll just use a microanisotropia so that the distance eye behaves like it's minus 0.75 at distance, but because of the 1.5 diopters, it actually has 225 at near. The distance eye set to plano has about a minus 0.75 at near. So both eyes are minus 0.75 in the intermediate, and that's when I stole from Dan Dury the term blended vision, and I called it laser blended vision, because it's blended vision the way he described with contact lenses and cataract surgery. And this evolved into a product. And, so back to my initial premise, I've been doing this for, over 20 years now. In just our clinic, we have treated more than 12,000 patients. We have 12,000 patients treated with everyone having had contrast sensitivity measured in the last 10 years with an OSI measured to show that they didn't have cataract. And we have 90% follow-up at 1 year with contrast and all of these factors. So we have data on longevity, enhancement rates, and obviously the efficacy and the safety. And the conclusion is that in the absence of cataract, someone with presbyopia, the treatment of choice, if they're a candidate for LASIK, is LASIK presbyond. Because not only is it a less risky procedure than an intraocular surgery, it's also more accurate. It has less side effects than diffractive or multifocal segmental IOLs. It's imminently and easily adjustable by an enhancement. And in the very few patients who ended up not tolerating it, which was 3% of the emetropic patients at 1 year were not yet adapted, right, it's adjustable or reversible. So you've got a procedure that has all of the features of what we would want in a presbyopic procedure. Of course, what we want is restoration of accommodation, but we can't do that. So when you compare that to the trend, the worldwide trend is lens replacement. And there's one argument which says, well, why are you doing laser if the worldwide trend is lens? I say, well, the answer is the worldwide trends is lens because we're going through an economic period where the younger patients don't have the recourses to necessarily pay for laser eye surgery. And those who do have disposable income to pay for refractive surgery tend to be the presbyopes. And they want to do self-improvement and they have the cash. So they go to an eye surgeon, and an eye surgeon can do a cataract surgery. Any eye surgeon can do a cataract surgery. We do cataract surgery. The difference is that if that patient comes to us, they know about refractive lens exchange because it's advertised on television, but we detect that there's no cataract using objective measures, contrast sensitivity, ocular scatter index. You can use the DLS. And then we explain to them that we have an option which is lower risk, more accurate, less side effects, adjustable and reversible. And obviously they opt for that. So this is a paradigm shift and in the understanding of what we should do. The question that comes up at the end of this is, but what if they get a cataract? And the answer is, great. Hopefully they don't get a cataract. In the UK, only 30% of people end up with cataract surgery before they die. Obviously, that's different in high altitudes and in the Middle East and tropics.
Right.
But you're only taking out the lens so that you don't get a cataract in the UK is not exactly a good bet.
Right.
But the great thing about getting a cataract after you've had presbyond is that you have perfectly modulated spherical aberration on your cornea set on your visual
On the
axis,
vertex, exactly.
which was done by an eye tracker. That means that with a monofocal IOL of high transmission, perfect transmission, and low PCO rate, we're talking about 2-3% PCO rate versus 80%, you can end up with your blended vision again by just taking the dirty window out and putting a clean window in. So a patient will say, well, but my friend had the lens replacement and they're really happy. And I say, well, yeah, they're really happy. But here's the thing. You're going to have a lower risk procedure, which is more accurate with less side effects now. So that's better. And then if you get a cataract, you're going to get a monofocal IOL, which is better. So you're better now and you'll be better then. So I've just given you kind of the arguments. I'm going to put all the science into the talk. But this is where we need to start opening our minds, I think. And I do see other companies going away from multifocal corneas, which gave corneal presbyopic surgery a very bad reputation. We got to stop that. I agree. But EDOF-based corneal presbyopic surgery is really the bee's knees. And the reason why it's easier for me to talk about this now is that the multifocal manufacturers themselves are going back on their word, are going back on their marketing, and now they're saying, oh, we have EDOF lenses. And it's like, yeah, you do. That's what we were doing since 2004, and we've published 3 papers ourselves. There's now 16 peer-reviewed publications on this in the cornea. And for me, EDOF IOLs is just it's presbyond by cataract surgery. And so it's funny how the industry has had all, monovision, multifocality, and they're all converging to the same solution of EDOF with a microanisotropia. And that's the optimized static solution to correct for the loss of a dynamic process called accommodation. Needless to say, if we could have a way of restoring accommodation, we can stop all these surgeries altogether.
Right.
And if it was a lunchtime procedure, even better.
I think, just like you said, I think also the advantage with correcting it on the cornea, like in presbyond, is that you could gauge the spherical aberration that you want, as opposed to when you put an EDOF lens, you could just put an EDOF lens irrespective of the spherical aberration of the patient, let alone also that you can center it dead on the corneal vertex, while the other is actually centered based on the limbus.
That's right.
And that's,
Well, we get the cases where someone's had laser eye surgery in the past, not with presbyond.
Right.
So their spherical aberration might be way too high or way too low. They might have had a -1 in a 6 millimeter zone on a Vizix 2020B and didn't change the spherical aberration at all. So in those cases with the cataract, what we do is we look at the vast array of IOLs available in the world.
Right.
And some of them have -0.27 spherical aberration. Some of them have plus 0.18 spherical aberration. Some of them are neutral. So based on the spherical aberration, we choose the monofocal IOL to optimize their spherical aberration and use a microanisometropia to give them 100% transvision, high quality optical vision without having to use a lens that splits light, either by splitting it refractively in a multifocal way or diffractively. And I don't want to sound like I don't believe that diffractive optics and refractive segmental optics are not good. I'm not saying they're not good. Of course they're good. Hundreds of millions of people have had these implanted. Hundreds of millions of people have satisfaction with these lenses. And one of the things that I am going to go through in my talk is comparing patient satisfaction with those devices of the last 20 years and with EDOF on the cornea. And I've got a beautiful analysis showing that the patient satisfaction rates published are the same, which leads most people to say, well, then it's the same. And I say, nah, it's not the same, because the satisfaction's the same, but if we look at the 2020 rates, they're very different. And obviously that's the case because IOL calculations, compared to LASIK, forget about it, right? Light adjustable lens, that's a different matter. That's a different matter. That's very, very accurate. And actually, Arturo Chayet, about 15 years ago, Calhoun Vision came to London. We talked about, we had a 3-hour meeting about how we modulate spherical aberration. I tried to do this a little bit like Barraquer, where you don't patent it. You just teach it, right? And I told them everything, and they went back and they did a study, 30 patients in Tijuana, where they modulated the spherical aberration and put the refractions on target. 95% of the eyes were within a quarter.
Wow.
Well, obviously, they're light adjusting them, right? The results were spectacular because they, unlike in the cornea, they could actually really control the spherical aberration and really control the sphere and cylinder. So then the argument is, well, why shouldn't everyone have a clear lens exchange with a light adjustable lens and everything's perfect? And then you come back to never yet and never may be that an intraocular surgery, removing the crystalline lens, will have a low, even an equal, forget about lower, an equal risk factor than a LASIK procedure. That's the barrier.
Right.
So that's where, in my philosophy, unless there's a disturbance in the optics of the lens, which can be either transparent disturbance or a refractive disturbance, meaning someone's hypermetropicizing every year. Why? Well, because the lens is growing, it's getting rounder, so it's making the eye more hyperopic.
Right.
Okay, well then that's not a case for a corneal procedure. You got to stop the movement. Unless there's a reason for tackling the lens, we tackle the cornea first, and we don't want someone to end up with a cataract, but we are ready and they are informed that they have a beautiful solution if and when they get a cataract.
Gotcha. Okay, so that's amazing, but I feel that this is just a hint of what you're gonna talk in the keynote talk. This is just, the icing on the cake.
This is just the short version.
Exactly. And by the way, this is also a hint of one can get when one goes to your course, the forefront in refractive surgery that you give in London. And we have tons of information. This is just an appetizer for the multiple courses that would follow if one goes to the course. I've been to your course, and I advise everybody to go and attend, and they will come back and better refractive surgeons. Thank you.
Thank you very much. We intend the course to be suitable for beginners because we go right down to the basics, but also for people that I learned from, like you, because we load it with scientific evidence so that everything we teach has the scientific backing so that you're equipped to have proper discussions with those who are trying to push something according to their experience without there necessarily being a scientific backup for what they're saying.
Right.
Perhaps not one of the elements of my personality that make me the most popular amongst my colleagues, but at least it's the way that I feel that I would like to gain respect. That's the way I've always been. I'm happy to lose some as long as the ones I gain are the real ones.
No, you're respected in everything, Professor Reinstein, and thank you for your time.
Thank you.
Thank you.